Hello, everyone, and welcome to School of Speech, presented by Speech Therapy PD. I am your host, Carolyn Dolby, and I am so glad you're tuning in today. This episode is Developmental Language Disorder and Dyslexia, Collaboration and Best Practices for the School-Based SLP. We are joined by the very special Dr. Tim DeLuca. Dr. DeLuca is an assistant professor in the Department of Speech, Language, and Hearing Sciences at the University of Massachusetts Amherst. That was hard for me to say. Wow. His research focuses on best practices for improving language and literacy outcomes for school-aged children, particularly with those with developmental language disorder, dyslexia, and complex communication needs. His work is grounded in years of experience as both a speech language pathologist and a reading specialist. I have so many questions. So before we get started, I want everyone to start settling in. I want to remind you that each episode of School of Speech is available for 0.1 ASHA CEUs through your Speech Therapy PD account. Some little housekeeping, I'll just do some quick disclosures. Tim receives a salary from a public university, and he's also receiving an honorarium from Speech Therapy PD for this presentation. Non-financial, Tim is a member of ASHA SIG 1, 12, and 16. For me, I am also a salaried employee at a public school, Portland Public, love it. And I do receive compensation from Speech Therapy PD for hosting School of Speech. Totally my dream job. Non-financial, guess what? I am also a member of ASHA, and I belong to SIG Special Interest Groups 13, 14, and 16. Enough about me. I totally want to get into today's topic with Tim. So Tim, hi, how are you?
Hello, I am very, very happy to be here. And I feel like between the two of us, we basically cover all of the ASHA SIGs.
Right? I mean, bring it. We're in there.
Yeah.
I am so excited. I want to know, here's what inquiring minds want to know, because here's my curiosity. First, I want to know your journey to become an SLP, because it's really great to get a male presence in speech pathology, being sort of female dominated. But I also then want to know how you focused on dyslexia. Which came first, chicken or the egg?
Chicken or the egg, that age-old story, right?
Yes,
So,
a tale as old as time.
of course. So I actually knew that I wanted to be a speech language pathologist for quite some time. I went right into undergrad knowing I wanted to be a speech pathologist because I had an aunt growing up who had Down syndrome, and she was born and went to school before a time where special education was a thing. So her life was kind of just like, good luck, hang out over there, and we'll check in with you later. But she gained a lot of language and literacy skills based off her own hard work, being around her siblings all the time, and the hard work of my grandparents. And I saw how much of the community, how many different job roles that she was able to accomplish over her time, and how much satisfaction that gave her because she had these language and literacy skills. So I'd always kind of had this interest all throughout my childhood, and eventually went to school for speech language pathology, graduated with my master's, and started practicing. And when I was practicing, I was working primarily with children with pretty limited verbal language. So students who were maybe limited speaking and using augmentative and alternative communication, many of them. And I noticed that a lot of them were getting no instruction in reading. And I knew that as a speech language pathologist, that was part of my scope of practice, but I realized that I had no idea what to do. So that led me to getting my reading specialist license, which then led me into the world of dyslexia, and eventually back to get my PhD as I learned more and more and more about all the kinds of things that we know in the research world, the kinds of things that happen in practice, and how often those things never meet. And I wanted to figure out how I can do better in connecting research worlds and practice worlds and making effective change for the different students that we might serve as speech language pathologists in schools.
Oh, wow. Okay, so you went SLP first, then reading specialist. I'm flip-flopped. I actually started out as, well, not a reading specialist. Well, yes, because I started out as a kindergarten teacher. So, and then
You
I
have
became,
to be, yeah.
yeah. So, yeah. Oh, that is so cool. I always love to know how we've all kind of got to where we are, and we all come from so many different it's so many different pathways. And I love that this really came from something dear to you and experience in your family. That's powerful. That is so powerful. And yeah, I am all for language acquisition and literacy, being a kindergarten teacher. So this is why I've been so excited for this episode, like really could not wait. But I need your help because I feel like sometimes we're not all on the same page when it comes to terminology and terms. So I'm going to ask you to just start us back at the basics, if that's okay. Do you mind just starting, because you're talking about developmental language disorder and dyslexia, and I know what I know, but I don't know what I don't know. So if you could like get us on the same page on how you define those, how we should be defining those terms.
Yeah, I think something that's so tricky is that depending on where we work, we all kind of have different demands placed on us for what makes sense as far as using different clinical terminology. And I think that's one of the really tricky things about being a speech language pathologist is that depending on the setting we're in, it's almost hard to communicate with somebody in the same role in a very different setting, just because the language that they're using, the way they're conceptualizing terms, might be really different to just meet the needs of their roles. So that's something that I think about a lot, and I'm hoping to contribute to us being able to think through a lot of these terms and see how they're similar, how they're different. So let's start with talking about developmental language disorder, and DLD is how we'll refer to it. And DLD is simply an oral language disorder. It's an oral language disorder that occurs without a clear reason. So we know that there's some biological underpinnings. We know that there probably is some aspects of nurture, our lived experience, that contributes to presenting with developmental language disorder, but it doesn't come from a clear cause like syndrome or some sort of traumatic brain injury. It just is developmental and it's lifelong, and it occurs within our best language. So I know this is a big thing that we think about now as SLPs, is that being multilingual is not a contributor to somebody having a language disorder, and using different dialects of a language is not a contribution to having a language disorder and should never be perceived as a language disorder. So when we think about DLD, we're probably thinking about a lot of students that we're working with if we're school-based SLPs.
Mm-hmm.
These are the kids that are on our caseload that have general challenges with either morphosyntax, semantics, or even pragmatics, the pragmatic language aspect. In the past, in research, a lot of times we're referring to these children as having a specific language impairment, SLI.
Yep, that's what I'm familiar with. Sure.
Totally. And so this terminology shift, DLD, came about in around 2017, 2016, 2017. There was this big fancy convention called the Catalyst Convention, where all these researchers got together with a lot of SLPs, a lot of people with lived experiences with language disorders, and they all came together and decided or talked about how we as SLPs should probably be better at using consistent terminology. So let's all get on the same page and decide what that consistent terminology will be, and also how we define that term. And through a bunch of iterations of going back and forth among all these different invested parties, that's how they arrived at that term, developmental language disorder. And it's the term that's been recommended, adopted by ASHA as how we're thinking about a language disorder that occurs without a clear reason, lifelong, in our best language. So that's what we're thinking about when we're thinking about DLD. If we're practicing in schools, though, we know that we have to use terminology that goes with IDEA, special education law, that dictates how we develop IEPs and qualify a student for special education. So in schools, we're often thinking about maybe a student qualifying for our services if they qualify under, in Massachusetts, where I am, it's communication impairment. In every other state, it's speech and language impairment. So make sure I code switch if I refer to the wrong thing there.
Oh, I'll help you.
Great, thank you. Thank you. But so that's often the terminology we'd be thinking about, or maybe we're thinking about an older student who's qualifying under a specific learning disability because their challenges with language are really coming out more in the demands of the classroom at later grades, where the demands are more in written language, being able to comprehend what we read and write to demonstrate what we know. If we think about the core features of why that student is requiring special education, that student has DLD, right? That's probably the diagnostic term we would use to provide a diagnosis for that student versus qualifying them under that IDEA special education disability category. There's a really, really great paper by some school-based practitioners and researchers a few years ago. One is Kim Mirza, and I think Erin is the other. I just want to make sure I'm saying the right
We
names. Yeah,
just
Barbara
had
Erin.
Kim
Awesome.
Mirza on.
Awesome. Love it. Love it. And this paper is a few years old, but they wrote such a thoughtful piece around, hey, in schools, we have so many things going on. Our workloads are so high, the demands on us are so high. Is it really worth us thinking about shifting our terminology, not only using the language in IDEA to qualify a student for an IEP? Now we also have to think about disclosing a DLD diagnosis and using that terminology DLD in classrooms. And I think that's a really fair point. SLPs in schools have so much stuff they have to do that shifting around this terminology and making sure we're using DLD in schools maybe seems like not a very high priority. But my perspective comes from, I feel like, a story that each of us has probably experienced with a different family we've worked with in our careers as speech pathologists. We can imagine maybe getting a student, coming across a student who's maybe like in third grade, and their parent comes to us and says, hey, my child has a number of disabilities. When they were around 2, they qualified for early intervention with a developmental delay, and it's because they have this language delay. So they have that diagnosis. And then when they were 3, they got services in a school that was also developmental delay. And then at age 6, they qualified them under speech and language impairment. And now the students in third grade, and now they switched it to SLD, specific learning disability, because they say that, reading comprehension is really challenging for the student. So there are all these different diagnoses that are the thing that all these diagnoses my child's carrying. There's so many challenges. And all along, that child just had DLD. The demands of their environment and the work settings in which they're receiving these labels, you require the use of different language, but all along, that person had DLD.
I'm sorry, I'm like mic drop right now. Those that are listening and not seeing us live, I'm sorry. I light bulb for a minute, because what I'm getting from you is like, it would have been family friendly and more supportive if we had just started with the diagnosis that it was. Did I just get that early on? Oh my gosh.
Beautiful. Yes. The one thing I do want to qualify is that DLD, we think about it as like a persistent challenge with language. So right now, the guidance is that we typically aren't diagnosing DLD till after age 5, because we know late talkers are a thing. A lot of late talkers catch up. So that like developmental delay piece is super appropriate early on. But if we can give a more specific diagnostic label earlier on, we can imagine that there might be a lot of benefits for both the child, their family, and even the whole educational team. Right? For the family, they now have an understanding, a thing they could go Google, resources they can go find online of like, okay, what is DLD? How do we support a child with DLD? There is an ever-growing database of really wonderful family-friendly resources developed online. DLD and Me is a great website that is US-based that has a ton of great references and resources for families. For the child, they now, just like we're doing with affirming all these different neurodiverse diagnoses that we come across within our clinical practice, like maybe a child who has co-occurrent ADHD, a child with autism. We're doing a lot of work in helping a student understand their diagnosis and self-advocate related to their diagnosis. We can start building that understanding for the student too, understand where their strengths lie, the places where they might have more challenge, where they might need to self-advocate more. Maybe that's going to help decrease feelings of anxiety, feelings of frustration in the classroom. And then for the school team, if we have this shared understanding that the student isn't like a child who has that diagnosis of SLI and then going to SLD with those 2 IEP labels over that 3-year period. This is a student that all along had DLD. And if we understand the core features of DLD, we can understand how it's going to present when we put different demands on this child. So in kindergarten, you know very well about kindergarten, it's a lot of like fun, talking out loud. We're all just engaged that way. So it makes sense that a lot of times we're picking up those kids for speech and language because that's the demands of the classroom. It's oral language that we're using all the time. Third grade and up, we're requiring a lot of reading comprehension, a lot of written expression. So it makes sense that SLD, specific learning disability, is maybe the label at that point because that's what the demands are. But all along, that's DLD. It's just presenting differently.
Okay. I think we're different from district to district on how we do the eligibility, which is something new because I spent a lot of time in Texas, 25 years in Texas,
Right.
and we had multiple, we would list, they could have or SLI, speech language impairment, had to be in one of the top three, and then whatever the other ones could be on there. Now I'm in Oregon in a new district, and they do it totally differently, and it depends on they don't call it DLD, but it's exactly what you're saying, but they're not using that term, so that if it is basically DLD, where it all comes down to who needs to be the case manager. And if they were only speech only, I hate that term, but if they're speech only, then the speech pathologist is the case manager and does all of it. Whereas I think I'm going to jump on your bandwagon. I don't know how, but I want to. If we use the term DLD, that would mean that the speech pathologist isn't the case manager, because it's more than just a speech, right? Am I getting that?
Well, so yeah, if it's SLD, and I think this gets into what we'll hopefully talk a little bit about later, is that interprofessional practice, right? Where because of how roles have developed in public schools in the US, a lot of our practice right now, just because of how things are designed, is really, really siloed, right? Like where we're only thinking about that oral language and that speech.
Yes.
And somebody else is only thinking about that written language. And it's all language. It's all language. And so there needs to be a shared understanding across the professionals who are professionals in language. And I think that, as we talk through that more later, hopefully that is something that we tease apart together. And I think it's so relevant that you shared your experiences and how different they are in these different states, because I think that's one of the really, really challenging pieces about like just how we're conceptualizing a student who might need our support. It's so driven by the expectations of practice within our setting, right? The labels I'm going to use, the reason I'm going to use them is so driven by the demands of our setting. And I think one thing we could do is just shift to, okay, I definitely need to do this stuff I have to do for my work, but also how am I best going to serve this child, this family? So you got to do what you got to do to get through your day. Totally understand that. But also, like, can we put in the paragraph where we're describing the child a blurb about DLD, so that there's that shared understanding of like, they qualified in this under this label, but here's what the diagnosis is. Here are how their strengths and vulnerabilities in language are presenting.
Right, because as we're writing in their present levels, where their eligibility, how it's affecting them academically, and it's going to affect them differently, each child differently, right? The same okay, good. Okay, I got it. Yay!
Yeah, because maybe it's more semantics for one person, more syntax challenges for another. Yes, exactly.
Perfect. Yep. Okay, I think I've got DLD now, which I've got it. All right, let's get into, can you define dyslexia for me?
Yeah.
Can you? I know you can. Will you?
Sure. Well, actually, it is a bit of a can you, because this is another thing where this idea of us being language experts, but we have all these different ways of labeling and describing ideas. So right now, there's, if we look in the DSM, there's a diagnostic description of dyslexia. If we look at the International Dyslexia Association, they have a definition on their website of dyslexia. And interestingly, just like for DLD, where they had that big convention where all these different people came and they all came to an agreement about the terminology DLD, the same thing just happened for dyslexia in the UK, where they brought together all these different invested parties. So people with experience, family members, teachers, therapists, researchers, and they redefined, or they updated the definition of dyslexia. And the same thing is happening through the International Dyslexia Association right now, led by Charlie Haynes and a bunch of other brilliant human beings, where they're updating the IDA, International Dyslexia Association's definition. So all that is to say is that there are a lot of different definitions out there, but I'm going to hone in on what I think are kind of those most important things that are consistent across all definitions, and that will really help us in thinking about, okay, who might be somebody with dyslexia?
We'll call this Dyslexia by DeLuca.
Love it. Love it. So dyslexia, very simply, is a word reading disorder. So it's a challenge with understanding how the sounds in speech map onto letters and how those letters might go together to form words. Dyslexia exists in all languages, so across all different types of orthographies, dyslexia exists. In a language like English, we often really can tell that somebody has dyslexia at the word level because we have so many different rules within our orthographic, the way we spell words, that breakdowns happen at the word level. In a language that's more transparent in its orthography, so the letters are used more consistently with more consistent patterns, we're often maybe seeing somebody demonstrate challenges with reading at that sentence level where they're having to read connected text and that fluency piece breaks down. So simply put, dyslexia, word reading challenge learning how to read words, often unexpected given appropriate teaching, expected cognition within typical limits. Those are two important things. I think especially, there's been a lot of news articles, a lot of research around the different curricula that have been used in schools recently, and how a lot of them maybe were not explicitly teaching word reading. So now we have a lot of students who may be presenting with challenges with reading, but maybe never truly would have been presented as having dyslexia, but this lack of instruction resulted in these extended challenges. So that gets really challenging to tease apart of, is this person that I'm working with right now exhibiting dyslexia, or do they need instruction? And that's when we could talk about things like dynamic assessment to see how they're responding to teaching. But all that to say, it's a little challenging, but big picture, dyslexia challenges with word reading.
Okay. I love to be simple. So dyslexia, word reading challenges. Okay.
And DLD, spoken language challenges.
Spoken language. I love it. Okay.
Right? Keep it simple.
So are we going to get it? I don't know. Where do we go? Like, how do we, okay, well, I'm thinking difficulty, identification. How do we identify in schools?
Yeah. And I think the other thing we could talk about is that they often co-occur together. So
okay.
Importantly, they're both behavioral disorders, right? There's not like a blood test for dyslexia or DLD, right?
Right.
We're not doing a brain scan on all these kids, although we know that people's brains look a little different. We're not doing brain scans on everybody. So it's a behavioral disorder. With any behavioral disorder, we as human beings are deciding, we're giving certain scales and we're deciding at this point on the scale, that's our cut point. And above that cut point, we're saying you don't have a disorder. Right below that cut point, and we're saying you do have the disorder. And that's a fallible system, right? It's human made, it's a behavioral disorder. So everything we say, we always have to think about what do these skills look like really functionally in this person's everyday life? And that's going to be the big important question that we kind of ask ourselves last to finally make that decision of, yes, I think this diagnosis is valuable to give for this individual and accurate to give to this individual, valid for this individual versus not. So when we talk about identifying any behavioral disorder, oftentimes the idea of the gold standard is a standardized test with really strong psychometric properties. The thing we want to think about there is the test that I'm choosing, it's valid for whom. So I have a child in front of me. I want to understand what their language experience has been so far. Are they multilingual? Do they speak a dialect that was used in the norming procedures of this test? If it's not, if they speak a dialect or have a multilingual experience different than that of the norming sample, then this test and the results are not valid, and I should not consider them as such, right? And that's always the important thing that we want to go back to reduce the likelihood of misdiagnosis or overdiagnosis, missing somebody, and then using more functional measures like language samples, work samples, reading and writing samples based on what the students learned so far, and aspects of dynamic assessment where we're teaching a little bit and seeing how that person responds to teaching. Because if they truly have DLD, truly have dyslexia, even if we're doing that good teaching, they're probably still going to need extra doses of that good teaching before they're going to demonstrate that gain. So those are kind of the big idea principles of how we want to identify DLD and dyslexia. And I'm going to go back to kind of where you started our conversation of like, why did I eventually get really interested in both DLD and dyslexia? And it goes back to that co-occurrence. Depending on the cut points we're using, a lot of people are saying that there's between 30 to 50, some people are even going higher than 50% co-occurrence. So if a child has a DLD, there's a 50% likelihood that they have dyslexia and vice versa.
Whoa.
Right?
That was a huge drop.
Yeah.
So you're saying we saying correlation or causation? Sorry, I just had to,
No, serious, but that's a real big question. Yeah.
Right?
Right, because we can imagine that somebody with limited reading experience is going to have less oral language development And so are they is that like that environmental factor that's causing that later presentation of DLD? I think it's a very valid question.
Which
when
came
I
first
think,
again?
right.
Chicken or the
And when I
egg?
think, yeah, when I think as a clinician, I could think, I almost don't care. I know that these challenges are here, so I need to address them. So that's how I like help myself calm down when I get stuck in that never-ending
Right.
cycle of like,
Oh,
what came first? What's really happening here?
yeah. I think the point that I think we should all hear is it almost doesn't matter. Okay, I know people are going to be like, what? It almost doesn't
Yeah, but I
matter
hear
what
ya.
we call it. We have to look at what are the deficits that are blocking the child in progressing in their education, right? Oh boy. That makes it almost a little
Right.
too easy.
Right. Well, and then I think like the question there is, if it does, we can think there might be a reason to call it something very specific.
Yeah.
And like going back to the question of what can that utility be for that family, for that child, for the overall educational team, if we have that shared understanding, we could probably serve this child better. So if we understand what DLD is, if we understand what dyslexia is, we can think about how it's going to present given a new task. Something I do a lot with graduate students, and I do a lot in my own clinical practice, is just giving everybody a task and saying, let's do a task analysis. Let's break this down into the steps and into the components of language it taxes. So is it more taxing on our morphosyntax, more taxing on our semantics, our understanding of how words get combined? Is it taxing on our word reading? You know, I might say we've learned how to read these kinds of words so far. So do we have enough knowledge to read these words? And based on all that, and based on what we know about DLD and dyslexia, that's when we can start seeing, okay, I know for this task, given this profile child, these are the challenges that might show up. And then I could proactively teach something, scaffold something to help that student, right? So it's a good way to start thinking through, yes, I understand the label, but I also understand what it means for this child. And if I understand both of those things, I can address any task that's going to come across this child's desk,
Okay, so
table,
I'm gonna go back and say, forget what I just said, that it doesn't matter. It absolutely does matter. Okay, I love this. I love mind shifting because it does matter, because DLD, but where is it affecting them? And is there a dyslexia component to it? Does make a difference on how you would support that child.
Right. And I think even just like buy-in of, okay, this child really has a challenge. I can think back to going to a teacher and being like, oh, this child's having some trouble with vocab learning. There's like, yeah, you know, a lot of kids in my class have trouble with vocab learning. But when we get that point across of like, this is DLD and this is what this means, then it's like, oh wow, this is a real disorder. I want to make sure I'm affirming this person's identity and what is true about them. So I have that extra buy-in now to work as a team to make sure we're appropriately supporting that student across the day.
Which I think is such a nice transition or segue, if you will,
I
into
will.
like, yeah, into let's talk about collaboration, because we can't do it alone. There's too much going on. When we're looking at DLD and dyslexia, it's not just an SLP situation.
100%.
Yeah.
Yeah.
How can we best support these kiddos? And I know you're going to say collaboration.
Right.
So let's
And
talk about it.
Yeah. And one thing that always frustrated me before I like really started diving into this is somebody would come to me and be like, you should collaborate more. And I'm like, sure. Yeah.
When?
What does that look like? What does that mean? And when? How do I actually make this happen? Right. So I think what we could maybe think through is what are different ways that professionals can collaborate, and then like start maybe honing in a little bit together on what big picture ideas we could jump onto to start creating change within our own work settings. All right. So there are three kind of big models I think about as far as what collaboration might look like for an SLP: multidisciplinary, interdisciplinary, and interprofessional.
Okay.
I see a big head shake. Is that familiar?
Yeah. Oh, I love. Yeah, it is. I love this. Yes.
Okay. Cool. So when we think about multidisciplinary, I think about this as like having to go to 5 different doctors. Like you go to your PCP, and then you go to the dermatologist, and then you go to whatever. But you know, that's multidisciplinary. All those people have their professions, and we go see all of them, but they don't really ever share their information with one another. or come to any sort of conclusion together about how to best serve
Everyone
the
is
patient.
swimming in their own lane. That's how I describe that one. Everyone's
Love that.
swimming in their own lane.
I love that. I'm gonna borrow that.
Yep. Steal it, call it your own.
Thank you. Thank you. Do you have a good analogy for interdisciplinary?
So interdisciplinary is where we don't have the line, I'm a swimmer. So you take the lines, the lane markers down, and we're all swimming in the pool together, sharing, well, no, we're with similar goal. We're working on the same goal. We're not keeping it separate. We're talking, we're sharing, we're gaining information from each other, working together.
Yeah. So I think that makes sense. So for interdisciplinary, I'm thinking about like we're sharing information, but like the actual work we're doing might be rather siloed, like the actual intervention, actual assessment, and how we're making decisions about the intervention and assessment might still be our own choice, even though we're getting the information from everybody else. So we understand what the OT is thinking, what the PT is thinking, what the teacher's thinking. Interprofessional is kind of the ideal thing we're working towards. And we have some evidence to support that this is a good thing to work towards, right? And I feel like this is really when we're coordinating our care. So we really have those shared goals and we really have shared decision-making that we're engaged in. It's not that I did a bunch of testing and then I showed up at the IEP meeting and I kind of heard what the neuropsych said and then wrote my goals. It's that I talked to the neuropsych and we decided like together, this is the thing we should do. In a really strong interprofessional model, we're also including the child, if appropriate, and their family members as a part of that collaborative decision-making process. I love a paper by Danica Pfeiffer, who's just a wonderful human being. And she has a paper that really describes when SLPs in schools really engage in each of these types of practice. And the only time, on average, SLPs are really engaged in interprofessional thought processes are really at that IEP meeting table. It's not before when we're doing the assessments. It's not really after when we get into treatment. It's really just kind of during that conversation at the IEP meeting where we're maybe talking through goals together. So I think that's important to not only think about where we are right now, but also to think about like, is that enough? And do we think it would be valuable to push that a little further and engage in more interprofessional collaboration more often? The huge issue is that nobody has the time, nobody has the resources, right, to make this happen.
Yeah.
So that, I think part of this is that we researchers need to work with teams in schools to create more data to support that. When we build models for interprofessional practice, there are huge benefits. We have this data in the medical world more significantly already where we see better outcomes for patients. We also see better outcomes for the actual clinicians. People are happier at work, they have more shared information, they learn more, they have better shared resources. And the big thing, this is how I, as a clinician, get buy-in here, is it reduces everyone's workload. When we all have this shared goal of what we're working towards, and we all know our piece towards how we're working towards that goal, and we're doing it effectively, it reduces everybody's work. The jump to there is really hard, though, given the systems that we all work in.
It is really hard, but if we want generalization, how, right. So I think I also heard the term transdisciplinary, which would be including, so I kind of thought of like multidisciplinary is all the scientific disciplines doing their own thing. Interdisciplinary would be the science disciplines working together. And then transdisciplinary is not only the ones coming from science, but also the families, the teachers, non-scientific, just as another way of looking at it too. But I think we are definitely talking about the same thing, that we should not be all swimming in our own lanes and with blinders.
Take down the lane.
Yeah. I mean, here's how we could do it. Multidisciplinary, you're swimming in your lane, but you have blinders on. Interdisciplinary, you're swimming in a lane, but you can see everybody and we're all passing over. Oh, hey, I like the way you do the butterfly. I'm going to do that. You're sharing your goodies. And then transdisciplinary, there's no lanes. Everybody's in the pool. I don't know.
I love it.
I don't know.
I think you're onto something. Like I can picture the infographic already. It's gorgeous. I love it.
All right, just throwing it out there, but comes down to like, but so how do we put some good theory into practice though? I mean, because
Yeah.
theory's great. So how do we put it into practice?
Yeah. So we can kind of think a little bit about behavior change. And one thing we know about behavior change is we need motivation to do it.
Mhm.
So how are we going to get people motivated, and who are the decision makers that help say change is okay? It's often administrators, people like that. And we have to show them that it's going to save money, save time, and serve all the different invested parties. So let's go back to what we know as speech language pathologists and what other professionals might know helping students learn how to read, because we know that all of those things are language, oral language, written
Yeah.
language, they're all language, right? So we know they probably need to have some sort of connection with one another, the way that a student's getting evaluated, instructed in those areas. If we think about, I always go back to just the simple view of reading, where we think about how a lot of times in school, the demands of a child is related to reading comprehension. They have to be able to read and learn from that text. So the simple view of reading says that reading comprehension is a product of our language comprehension, that's the SLP, and our word reading ability, that's classroom teacher, maybe a special educator or a reading specialist, should a student need that additional support. So we already kind of have a model that says, hey, if we want reading comprehension to work, these people need to have the ability to collaboratively work together, right? To get to that end goal of reading comprehension. It's really well researched. There's a lot of data to support it. So boom, we know that already. And the other way we can get an admin to buy in there is like, hey, that's the test every kid takes, no matter if it's a science, social studies, math. So much of that test is really just reading comprehension, right? It's basically reading comprehension. Everything we're doing is reading comprehension. So like, if you want our school to look good, we need to improve reading comprehension. And we all know how to do it, but you need to give us that time to actually get together and work on it collaboratively, right? So that's one inroad I think through. It's just taking the simple view of reading and showing here's where our roles are, and to get to that outcome we all want, these roles need to overlap and have that shared knowledge and treatment and evaluation. The other thing I think we could think about is that right now we don't really have good models of like a lot of public schools doing interprofessional practice really, really well. I'm sure there are a bunch of places doing it really, really well, but we don't have that super well publicized as a clear roadmap for how every school can do it.
Okay,
So
if there's anyone listening right now and your
Yes.
district is doing a phenomenal job of interprofessional practice, I'm going to need you to get in touch with us because Tim wants to talk to you.
Yes. Oh, that is the best plug. Thank you.
Right. So yes, so reach out to us because we want to collaborate and
Yes.
get your secrets.
Learn how you're doing it. Right.
Yeah.
Right. Totally. So
Okay.
the way I'm thinking through this is now I'm in a role where my primary responsibility is producing research and my goal with my research is that hopefully it's going to be applicable for clinicians and also include clinicians in the generation of the work. So right now, what I'm doing is trying to build more research practice partnerships where I am teaming up with schools and really spending time in those schools, learning about what their systems look like and learning about what the facilitators are to help us do the work we want to do and what the barriers are to getting that work done. I use a lot of implementation science methodology, which is a fancy way of saying how we take all the stuff we know looks good, is efficacious in a really controlled environment, and how we make it effective in the real world, right? So that translation of how the stuff happens in a lab to actually taking place in a school, because we know, I can't count how many times I've read a research paper as a clinician and been like, cool, I never could do that. So what do I take from this, right?
It's the thought of like I remember taking the praxis to become a teacher, and they just kept saying, when you're going to take that exam, the question is addressed to you as if that student is the only student that you have in that classroom. So your answer is supposed to be if you had all the time, all the money, all the research or resources, and you just had one student. And that's the answer they wanted us to give. But come on, folks, that's not real. Right?
And it's almost like an inaccurate demonstration of knowledge then, right? Almost, yeah, not accounting for the real world.
No, I'm sorry. School-based work is a full body contact sport.
That's very true.
And we need to come equipped.
Yeah.
So you're helping us.
Full body. So what's great about implementation science frameworks is that it really just helps us think through, what does this particular school environment look like? And what is the larger environment it's working within? You just gave such great examples of how different districts kind of follow different rules and mandate different expectations around what we're putting on an IEP and how we're classifying it on the IEP to then engage in certain treatment, right? We have to understand, is that coming from the district level, at a school principal level, specific team within the school? So when we can start accounting for like the inner setting variables, the outer setting variables, then we can think about the actual individuals there. Who are the people we have to serve? Who are the people available to do that? Who are the family community members? And then we can think about the actual innovation or treatment, assessment, whatever the new thing is we're bringing into the environment. Right now, we're kind of talking about interprofessional practice, right? That would be our innovation, how we're building opportunities for interprofessional practice. If we account for that stuff in the inner setting, that stuff in the outer setting, and the individuals there, we can start to piece together an entry point for how we would introduce that innovation of, first steps in building in more capacity for true interprofessional practice. Then the other piece we could think about are, what are the implementation supports we need? So is there maybe somebody who is in that research role who has more time because I don't have to treat kids all day, who can come in and help provide resources, help be that middleman communicating ideas between different parties until we can really find the space and time for everybody to get together. So how can we put other supports in place that facilitate building in this innovation in this new setting? And so that's a lot of what I'm thinking about with different school systems. And the more we start clarifying all these different details in different school systems, the more we're going to be able to build a generalized set of knowledge that hopefully can inform any person in any school in implementing interprofessional practice more effectively in that particular setting.
I'm yes.
You're
I'm
on?
like yes.
Yeah.
I mean, but it seems sometimes things seem so easy when you say it.
Yeah.
But so there's just so much going on. But I think if you got every single speech path together and we are bogged down and we're all that nonsense, we would all say the same though. If we could, we would. If we,
right.
We all want to do this. So we need to figure out what is the barrier to their could. Like they want to if they could. So how do we get them so that they, that they can?
Right. And that's exactly what we would do when we first start working together with schools, is thinking about like, what are all those barriers? What are all the things in the way? And then how do we start slowly shifting those so that we can flip them into facilitators somehow, right? Getting the right people on board, helping people understand the benefit of the changes we want to make, and then just creating small incremental change to, these very, very long standing systems that teacher has been doing the certain thing for a certain way for a really long time. How do you start creating those small changes that are acceptable and appropriate for all parties? And it's certainly not easy. It takes a super long time, and there are a million hiccups along the way. So fully acknowledge that there's not a perfect formula at all. But it's something I think it's important work for us to do, because I do think, we have to really understand the profile of the learners in our schools. And I think right now, based on how most school systems operate, we're probably not doing the best for these students. And that matters. I think another way we could think through this is getting even better data longitudinally about people who are experiencing DLD and dyslexia. The data we do have demonstrates that if DLD and dyslexia are not well supported early on, individuals are more likely to have challenges getting to the academic level they want to get to, obtaining jobs, keeping jobs, building emotional relationships with people, keeping social and emotional health. And eventually, if not well supported, these people might actually cost taxpayers a ton of money, right? So it's even that mindset of like, let's think really, really big. And I think there are a lot of people doing this work to think about moving high level policy differently by showing how that bottom line can be influenced.
Because you explained exactly the reason we actually have school. Like,
beautiful. I mean,
I know.
Great way to boil it down. No, it's wonderful.
it's kind of how I am. I'm like, I'm kind of, yeah, let's get it, like, so this is what I do. Like, I want to get somewhere. I might go all the way to the ridiculousness, but then then I'll come back to like, wait a minute. This is, because at first I was like, okay, this is too much. This is,
Yeah.
I'm getting overwhelmed and but then as I kept listening to you, talking about, how it affects the student in their after school, right? And in work and relation, in their mental health. I'm not sure you gave us like 8 and it was beautiful, but my light bulb went on again when I thought that's exactly why we're here. So basically everyone needs to get back on board to figure out and all realize why we are at school, and maybe reframing it that for maybe those of our friends that need to be slowly walked to the epiphany. They can't jump right to the epiphany of like, we are doing this. Slow
Right.
walk them to realize, and it's so exhausting, I know, until they really what's exhausting? It's exhausting to get somebody to think of this to be their own idea, because that's how you get that buy-in, right?
Love that. Yeah.
Well, that's not that I want to bring up my ex-husband. I love him. He's amazing. But I had to do that a lot with him. I had to like lay these little things around until it came, oh, we should go on a drive on Sunday. Oh, would be a wonderful idea. Okay, that's silly right now. We can just
No, but
but
I think it also speaks to a speech language pathologist's strengths, because how often are we doing that in pediatric speech language pathology, right?
all
Is
the
getting
time.
students to think it's their idea to
All
do the
right,
thing.
so yeah, so I guess we need to use our superpower, our
Right.
speech path 3, like wizardry,
Yeah.
on our. So once we're bought in, I'm in. We then need to get everybody else in and okay, this is another thing. You're really making me think, and I'm loving this. All these light bulbs are going on, because what we shouldn't do is go to our campuses and say, hey, guess what? We need to do this. Because you know who does that to us and pisses us off, excuse my language? Admin come in and say, do this. And we're like, and we should be doing what we want to have happen, is the why, and understanding why we are wanting to do this. Oh,
I love that. And I think going back to your beautiful summary of just, this is why we have school, right? You and I are talking about DLD and dyslexia, but this is true for all students. If we think about, there's so many, news stories every year about NAEP, the National Report Card of how students do on their English and English language arts tests and things like that. And there's always a different policy change or initiative happening at a national level for kinds of curricula that should be in school to better support students.
Right.
And nothing ever really gets better.
No.
If we simply go back to that simple view of reading, we're still keeping all the instructions so siloed. So maybe we're intervening a lot on word reading for all students. Maybe we're intervening a lot on love of language and using language, but we're never really meaningfully connecting those two ideas. And we know that the meaningful connection of those two ideas is how that reading comprehension piece actually changes. And that's how schools are going to look like they're doing better. So, we've been talking about DLD and dyslexia, but the ideas that we're talking about are really true for all learners. We need that strong oral and written language foundation to be successful in schools, the way schools are set up right now. And so, if we really want to get buy-in, we can zoom out and say, this is so true for all of our students. SLPs maybe don't need to be only treating at that tier 3 level of the MTSS system every day. Maybe we're more supporting how we're changing curricula to best meet the needs of varied learning profiles within different grade levels and classrooms.
Right. And again, it all comes down to collaboration, right. And I love the idea of not being siloed and that we're all in it together. The concept of that all students are general ed students first. That is a big thing that I talk about all the time in my practice, is that all our students are general ed students first. And so what are the supports they're getting in general ed supports?
I like that.
Yeah.
My mentor, Tiffany Hogan, always says, they're all our kids,
Yeah.
right? Another nice, succinct way to get that point across. They're all our kids.
Mm-hmm. And so the so the we can share like our specialty with all kids, when we are collaborative, when we're working with the teachers and we're showing the teacher, we're talking with the teacher, and then we can gather more information and learn more when we're learning from our colleagues in other
Right,
disciplines.
right, exactly. We understand why the child needs a certain positioning when they're trying to write. We understand why they're learning sounds in certain sequences for their reading curriculum. I worked with a school a few years ago, and there was a lot of buy-in from the admin. So within one of the schools in the district, the SLPs were really able to change their model of instruction or intervention, where prior they had been doing a lot of pull-out intervention, and they were able to shift a lot to more push-in intervention when they deemed it appropriate for students, and also move more students to having more consult time on their IEPs, where the SLP was really meeting more with teachers and other professionals in how to best support the student, and also modifying aspects of the curriculum to better meet the needs of the student in that general ed setting. And they ended up having some really, really nice data to demonstrate progress for students and also staff. Staff were like, oh, now I understand what that person does and why they do it so much better. Now I'm not annoyed when that person comes and tries to pull a kid out of my classroom, right? How often do we get that teacher? Like, now's not a
All
good
the
time.
time. You
So
know,
that building that shared understanding is just such a nice piece of this. And I want to make sure that I'm really clear that I'm not saying that we need to increase our workload as SLPs. We have plenty to do. I'm
right.
thinking long term about helping us decrease our workload through this idea.
Right. No, and it does. But here's okay, I don't, sorry for all private clinicians out there, and I don't mean any disrespect, but here we go. I find a lot of time, not a lot, I have found occasionally a parent that has perhaps been going for private therapy, and they get an hour of SLP, hour of OT, an hour of it's very multidisciplinary, very separate. They're all in their own lanes. And then they come to the school, and first of all, that's a big difference on how we actually provide services. And all of a sudden, OTs are able to discuss how they are, a collaborative approach. PTs do that, I think, very well. I'm not sure SLPs, we do that as well, explaining and really pushing for when it's appropriate, because for that push-in collaborative approach. And there are some students that absolutely you need to pull out direct instruction. Definitely with some of the, when we're looking at our TIC, we're looking at fluency, some of the voice, some of the other things that we need to work specifically. But I'm on board with doing more collaborative push in, because again, everybody's winning at that point. When it's appropriate for that student, everyone's winning. But I think one of the barriers for we would, if we could, sometimes we feel that we're getting pressure also from parents that are like, no, I want them to have, I don't know if you have any help.
Yeah, no, I get that. I worked when I was in schools. I was also working privately after school. And it was so interesting. I'd see, kids with very similar profiles, and I'd say one thing in the school setting to a family and the exact same thing in the private practice to a family. And in the school, they were like, no, you're wrong, can't be right, disagree. And then when I was in a private clinic setting, they were like, that is the most brilliant thing I've ever heard.
Right.
And it's just that perspective of, I think a lot of times family and trust with the school system is a huge thing we need to build up. I totally had that experience too, where families just want as much pull-out service as possible, because we think then about dosage being better or dosage being more, and therefore therapy probably being more effective. It's the model that all of us kind of know. If we've been in schools, that parents have been in schools, they maybe have some experience in knowing that an SLP usually was pulling a kid out of the classroom for support. So I think part of the thing that we could do is just create more awareness of what we could do and where we can do it as a field. And I think that's another really nice opportunity for that collaboration, that research practice partnership between school people, researchers, to develop that data, demonstrate that information in a way that is going to get that buy-in from family. And I don't know of a place where it really exists. I also think that we could We have some research around treatment effectiveness. We have a lot of research around treatment effectiveness in very specific research settings. We have less of that research effectiveness work happening in, pull-out school settings, and even less less stringent research supporting, things like push-in services. It exists, but it's harder to find. And I think if we build up that data in a really ecologically valid way, that might be a nice way for us to get buy-in to, which doesn't handle anybody's challenges at this moment, but hopefully is a nice direction for us to think towards, and ways that we could really work together to begin to create these shifts. And I know if I were listening to this, I'd be like, yeah, but what do I do tomorrow, right? So I think part of this is just even starting to share these ideas with other professionals, right? Other people from other roles within our school systems, to start planting these seeds of how could we work together? Should we try, actually, let me do a push-in once a week, and let me try to help that ELA lesson a little bit. Here's how I'd break it down for these kids, because I'm working on, shape coding and morphosyntax support with a bunch of kids in your classroom anyway. So let me just come in and try it here for this lesson this week, and let's see how it goes, to start getting that buy-in from other people at a small scale.
I like that. I always like to think about, okay, I want everyone to leave with something that they can do tomorrow, and the greater scope, I don't want to forget, because it was in my head that I wanted to say, if there's anybody listening that's looking for research ideas, let's get into like the efficacy and the student outcomes of push-in model, school specifically. Yeah. So please do that, and then get in touch with us. Let us know what you found, what you
I
find.
love these plugs.
I know, I love it. I love it. But then I wanted, okay, so let's go back, because we are getting towards the end, and I want us to get back to like walk away. I want everyone to have some walking away money, or as my ex would say, walking around money. I love that. I do love him. Yeah. How should we end this? What are
our take homes, right?
Yeah, just take homes.
So I think one thing I'm advocating for is us as clinicians being more specific around the diagnostic terminology we're using. Yes, within our settings, we might have to use IDEA language. Maybe if we're in a private practice, we're using ICD-10 or 11 billing language, right? But what is the one label we can share with a family that's going to help them understand what's happening with their child, or even for the child, what's happening with them, and where they can go to get resources? So I think one thing that I'm really advocating for is us to start saying DLD more, start saying dyslexia more. I know a big piece of pushback that we often get there is that schools are often discouraging clinicians in schools from diagnosing. There is no law that says we cannot indicate these diagnostic labels. And in fact, the Office of Special Education, it ends with a P, OSEP. I have no idea what the P stands for. There's a letter that they wrote that reiterates that we can totally say DLD in an IEP, and we can absolutely say dyslexia on an IEP. If you just Google OSEP, DLD, dyslexia letter, I think it'll come up. ASHA, maybe you add in there. So, and I could share that even with you if it's a helpful resource too, so people can have that letter in hand to say, hey, look, we can use these terms in this school.
I need this. You again, I have to stop you, because a lot of times I'm hearing, oh, we don't say they, we say it appear, we are suggesting whatever in the IEP that, but you're saying that we can actually use that diagnostic term. I love it.
Exactly.
Okay.
Yes.
That's huge.
Yes, it's huge, right? Yeah. Because I that was always a concern I had practicing, is that I never knew I could do these things, but we have specific letter from the federal government saying this. So we can hopefully feel more comfortable with that. And then when we now have this shared terminology, we can start building shared understanding of the terminology across the people with whom we're interacting, whether it be other professionals, family members. And then from there, when we develop that shared understanding, it's going to lead us into that interprofessional practice more easily. We're going to have more facilitators to do that, right? So I know we talked very lofty and kind of big ideas today, but I think there are some simple places to start, of starting to use the terminology, starting to spread awareness, and little by little, we can create these interprofessional practices that really support our learners' outcomes.
Wow. Okay, it's too soon. I love you. I'm just kidding. I'm just kidding. I'm such a freak. I love this. Okay, takeaway. Shared terminology turns to shared understanding. And when you have shared terminology, shared understanding, you will start interdisciplinary professional collaboration. Hopefully.
Yeah, it's one of those major
That will-
components. Yeah, it's
what
one of
will
those
birth it.
active ingredients. Yeah, I love that. That was a perfect, succinct summary. Thank you.
I'm trying. No, I love this. Oh my gosh, I cannot believe, okay, we are at the end of our time. I cannot begin to thank you. I have learned so much. This has been amazing. Tim, you are an expert and your insights have been amazing. I now understand developmental language disorder as I hadn't before. I loved your easy term for dyslexia. Now I just forgot it. Reading, what did I write it down? Word reading, right?
Yeah,
That's-
word reading challenge. Yeah, that's
So,
the thing we're looking for.
Mine
Yeah.
was short-term memory challenge right there, but word
I saw it on your
reading.
lips for a second. I
Right,
saw
it
the
was there.
format,
It
yeah,
was right there. And I absolutely love the way that you, being a researcher and a practitioner, how you have this passion and to bridge the research and practice. It's truly inspiring. So I want to thank you so much. And I hope all y'all that are listening are walking away with some renewed energy for some collaboration and those first steps. And easy one, shared terminology. If that's the one thing that you do, you turn for tomorrow, shared terminology. I love it.
Excellent.
Love it.
Thank you so much for having me. This was an incredible conversation, and I hope we got some points across that'll be helpful for listeners and interesting to listeners. And I'd love to connect with people, so feel free to reach out if you want to talk more about anything we talked about today.
How best if somebody wants to reach out to you, is there a way that we can get a hold of you? What would be the
feel
best
free
way?
to email me. It's my name, Tim DeLuca at umass.edu. So it's I think my most simple email I've ever had as a professional. So I love it.
I love it. Yes. So please reach out to Tim. I love it. All right. I can't believe it, but I have to say goodbye. All right. Bye, everyone. Thank you so
Bye-bye.
much. Bye-bye.